I think in reality, we're all punching ourselves every day because we're all becoming more in the middle here. And in contrast to David, I wish I had 4 randomized trials to talk to you about in a field that has thousands more patients probably in terms of these therapies, but we don't. So I'm going to talk mostly about philosophy, a little bit of data, but more about philosophy, and I think key points that we all use in everyday practice that help us figure out the right thing to do for the right patient. We'll review some of what I would consider the key principles from a vascular perspective pertaining to patients with advanced limb ischemia, and particularly those with wounds. And I think what I really would like to do is make sure everybody understands that the limitations for each of these things are a little bit different. So if you understand how they complement each other, you can realize that there are actually better times to use each type of intervention. And that leads us hopefully to a rational approach until we get level 1 evidence from randomized trials to guide how we treat patients every day. So just again to review why we're even talking about treating vascular disease in these patients, because some would say they have such advanced vascular disease. Well, they obviously have pain, they have wounds, and we're trying to preserve function in their lives by preserving a functional limb. And so for this, we believe that really effective revascularization is an absolute cornerstone to achieve these endpoints. At the same time, we recognize they have lots of comorbid disease, and so we must at the same time maintain aggressive medical management of their overall comorbid status so that we assure good quality as well as life expectancy. So here are some of the key clinical points just from the standpoint of the vascular surgeon treating the patient with advanced limb ischemia. First, we realize that these patients have very high risk. In fact, multiple studies have shown that patients with advanced limb ischemia actually have a higher risk of major adverse cardiovascular events and mortality than those presenting with an initial myocardial infarction. However, don't be nihilistic because most of these patients will survive for at least 2 years. With current medical therapy, more than 70% will. So therefore, durability is important. With advanced ischemia, as pointed out yesterday, time is tissue. We need to move quickly and get effective vascular supply. But it's also important to realize that when our procedures don't work or fail, that the symptoms generally will recrudesce. It's not the exception, it's the rule. We all know that ulcers will recur in 20 to 80% of patients. Bottom line here, for most of these patients, patency does matter. And we know this is a chronic disease, sort of like congestive heart failure. It requires management, multiple treatments, and surveillance and long-term care from appropriately dedicated multidisciplinary experts. So we know we have lots of options to bring to bear, and our challenge every week in my group, it's every Tuesday morning at 7 o'clock. We talk about all of our pre-op cases for the week, and we scratch our heads and we try to figure out what's the right thing for this patient at this moment. We know certain things about open bypass surgery. We know less, but we are increasingly gaining knowledge with different tools in the endovascular realm, and we're trying to face these decisions every day with really limited evidence. So let me start with just a quick case, because critical limb ischemia is sort of easy to recognize when it's right in front of you. This is a 58-year-old gentleman who has diabetes, he has stable coronary disease and hypertension. He's never had a vascular procedure before or a CABG. He showed up at one hospital with foot pain. He was admitted overnight. There was no vascular exam recorded. He got IV antibiotics. He was sent out the next day on oral antibiotics. 4 weeks later, he came back to the same hospital ED with pain, redness, and an ulcer on his foot between 2 digits. Somebody took a plain x-ray, said it was not remarkable, and discharged him on oral Keflex. Again, no vascular exam was recorded. Predictably, 3 days later, he came back with worsening pain and now gangrenous changes involving 3 digits. And finally, somebody noticed that there were no pedal pulses. He got admitted. He had evidence of systemic inflammation with a white count of 20,000. He got IV antibiotics. He got a vascular consult at the outside hospital. He had an angiogram with iliac stents being placed, and he was said to have significant femoral and infrapopliteal disease and was transferred to us. And this is what his foot looked like when he got here. So clearly, as I said, time is tissue. Time's already been wasted. This patient's opportunity to save his entire foot was probably already lost by a delay in diagnosis. You can see that the redness is spreading on the bottom of his foot, and you know that inside the foot there's a lot more necrosis than meets the eye from the outside. His angiogram at that time, it's actually the leg on the right. The SFA is open, but just at the bottom of the panel, I'm sorry, it cuts off. It occludes at the adductor canal, and the entire popliteal artery is occluded, and there's reconstitution of tibial vessels in the upper calf. So this patient is a patient who is a younger patient with extensive tissue loss. He has a saphenous vein. We did not, getting this arteriogram, attempt to cross any of these lesions. This was, from my standpoint, a straightforward surgical decision. For this patient, he would need a bypass, and he had good runoff targets, and that's in fact what he got. He got a saphenous vein bypass graft to that target. He got a completion TMA, and this is him 9 months later with a fully healed foot, and he's been walking with a prosthesis, and he's back to full function in a construction job. That seems like a straightforward case, except not everybody in the country would agree with that, and some would probably have tried to cross that lesion and do other things. And that's probably the most straightforward case. There's a lot of cases that are much more in the middle. And as Joe Mills pointed out yesterday, when we talk about tissue loss in these patients, it's a wide range of lesions and a wide range of ischemia. It's quite a heterogeneous cohort. So all of these subjects here on the lower right, this patient would probably still be able to get a TMA with possibly some modification. The lower left is a infected wet gangrene, which is a surgical emergency. And then we have a chronic wound on the upper right that's been present for 6 months, and then a tiny little non-healing wound on the upper left. All of these fit into the Rutherford 5 category. So when we read the literature and try to understand which technique is working best, we are really handicapped by this classification scheme because clearly the natural history of each of these lesions is quite different. And that's why we heard yesterday about the importance of the new Wi-Fi system. We will see if over time this really does prove to be predictive of healing in the way that the stages were laid out. But at any rate, it allows a much more discriminating way to resolve the spectrum of disease that we're seeing. And it's critical for us to go forward with this platform to really compare what works best. The other key point that was made yesterday, I think by Dr. Schneider and others, was the limitations of the reporting of limb salvage as the primary outcome in revascularization. This is actually a curve showing limb salvage in a CLI population. This was actually supposed to be unreconstructible patients getting experimental medical therapy with a prostaglandin. These are no-option patients who basically were randomized to aspirin. The treatment itself had no effect, and they had an 87% limb salvage at 1 year. Every time you see a study of a revascularization technique that reports limb salvage of 85%, keep this in the back of your head. A lot of these patients, depending on the spectrum of disease treated, will not necessarily lose their limb in a year, particularly if they have rest pain and minor tissue loss. This is a very insensitive way to compare the outcomes or the quality of revascularization. What we're trying to achieve with revascularization is sustained hemodynamic improvement. That is the most clear and effective and direct measure of revascularization therapy. Unfortunately, it's not what's in our literature. So what do I look at for general principles in these patients? First of all, I think you always need high-quality imaging for planning these revascularizations. This means a digital subtraction with dedicated multiple views of the ankle and foot. Axial imaging alone for planning these sorts of reconstructions is typically not adequate. I think it's still an important principle to restore straight-line flow to the foot, especially in cases with tissue loss. Pulsatile flow improves healing. And I can tell you, because I've seen it, lots of times patients will get treatment of proximal lesions and will leave distal occlusions behind. This will never really work for wound healing, or in most cases it won't work for wound healing. And finally, as I mentioned, surveillance and vigilant follow-up need to have a low threshold for changing your strategy or re-intervening or converting to open bypass surgery for endovascular failure, because again, time is tissue, and these patients, they get recurring lesions, they also get recurring pain, and their lifestyle is markedly inhibited. The key factors that you need to have, you can get mostly out of the first visit, and the ones that I've highlighted here, obviously the general health of the patient, what's the likelihood of salvage of a functional foot, what's the state of the foot and the severity of the ischemia in that foot, what kind of prior vascular interventions have they already had? Have they already had a bypass? Have they already had stents placed? And what vein do they have available? All of those things I can get before I go to the angio suite. And I would tell you, you need to have all of those pieces of information in your head before you go to the angio suite and you start thinking about crossing lesions, because you should really make your decision with all of that knowledge as a background. And the final piece is the anatomic distribution of disease, which certainly plays an important role in the decisions. I'm not going to talk a lot about data. There's just not enough time. Clearly, we know that endovascular treatments continue to evolve and are continuing to improve in terms of technology. We have better wires, catheters. Drug elution is holding promise. Clearly, it's less invasive. Patients recover faster, and it may be repeatable. All of these are advantages. However, for the CLI patients, some of the disadvantages are real, including reduced efficacy in terms of hemodynamic gain as well as durability, and generally this is in the patients with the greatest need, the ones with the greatest lesions and the most to lose. There is a real risk if it's not done carefully of limbs deteriorating, and it certainly can affect surgical options, particularly if implants are placed in the wrong locations. And it's costly. The techniques, unfortunately, are not standardized across the literature, so it's really difficult for us to compare data in a careful way. I mentioned some of this yesterday as far as the real-life challenges when approaching CLI patients from an endovascular standpoint. These are common factors we face: multi-level disease, both the femoral and distal, long segment disease and chronic occlusions are very common, and extensive calcification is frequent. Each of these factors is independently known to be a factor that impedes the outcome for endovascular treatment. And when you add them up together, which is not infrequently the case, you start to reduce the ability for benefit. So those are all negative factors. In addition, as we mentioned, advanced tissue loss requirements need to be thought about. You need to be able to support healing over a protracted period of time. The patient's comorbidities may slow wound healing. There's concomitant infection and also weight-bearing stresses. And finally, the importance of durability for many of these patients is real. As we know, diabetic foot ulcers tend to recur. You don't want to be wondering about the vascular supply again 6 months later. And the majority of these patients are going to live at least 2 years. So when you're looking at 6-month and 12-month patency data, it really isn't going to tell you what the patient needs to know or what you need to know for the long term. We've already talked about the task classification and how limited it is. It's just a background slide to say that there's a lot of unknown in the middle, but most of this classification scheme was based on femoral popliteal disease. It's considered to be outdated at this time, but it points out that longer segment lesions, and particularly lesions involving the popliteal and trifurcation, are considered to be preferred for surgery, whereas focal lesions are considered to be preferred for endovascular. An important caveat is that there's no mention here about vein quality, which is really the dominant driver of bypass surgery success. So now let's talk about what affects bypass surgery. And again, I mentioned that we really should be focusing on the whole limb, not just each specific lesion, because the success is really a multiplication factor of each lesion for endo. What do we know about the overall results, I think, for endovascular treatment? They're respectable, and they certainly seem to be improving. And if you look at this particular meta-analysis that was now done 5 years ago, it looks at plain old balloon angioplasty for infrapopliteal disease, which is still the dominant mode of endovascular treatment below the knee, I would say. You can see that the patency rates are not as good as they are for bypass, but again, the limb salvage rates appear to be reasonable. And so this data suggests that certainly balloon angioplasty can be effective, but that the patency is clearly not as good as bypass. And you have to be careful again about the limb salvage data, because this is a mixed group of studies from a mixed group of patients, and they're certainly not all looking like those extensive tissue loss patients that I showed on the previous slide and the case that we just showed. What about bypass surgery? Well, I think it still is the gold standard. When done with vein, we have lots of data about how well it works. It's certainly versatile anatomically. You can use it in lots of complex situations. The mortality is low and the durability is good, but there are real limitations. Comorbidities lead to end wound complications in 10 to 20% of patients. Mortality is about 1 to 2%, but it takes a while for patients to recover. About 20 to 40% of patients may not have an adequate vein to use. They need surveillance and reintervention as well. And it's a technically demanding procedure that's not actually done equally well in all centers, and that's just a truism. We need better risk scores here also to help us select patients who would be optimal candidates for bypass. We heard from Dr. Schneider yesterday one approach, and there are others out there. We'll talk a little bit about that. The bottom line, the PREVENT-3 trial was probably the largest data set that we have in critical limb ischemia patients, and just to give you an idea of the overall early 30-day events and sort of the safety of the procedure. And this is a pretty high-risk population at 80 hospitals across North America. The perioperative death rate was 2.7%, early graft failure was 5.2%, and early major amputation was 1.8%. I think these are numbers that we can consider should represent reasonable quality limb salvage bypass surgery in centers of excellence as a benchmark. I would point out that these were not cherry-picked cases in this particular trial. 3/4 of these patients were Rutherford 5 or 6. 24% had high-risk conduits, and more than 2/3 were to tibial and pedal targets. And the one-year outcomes in terms of patency are shown here, primary assisted and secondary patency ranging from 61 to 80%. And this was a trial that was focused on identifying vein graft lesions, accounting for a significant number of prophylactic reinterventions. What do we know also about what affects bypass surgery? Well, vein quality is the dominant factor. So this is a different math than we do for endovascular. If you have a good quality saphenous vein that's greater than 3 millimeters, you can see that as you go up to 3 to 3.5, the outcomes in terms of patency are significantly different. And if we looked within this trial alone at about half the patients who had their bypass done with a single segment of saphenous vein of adequate size, their 30-day failure rate was about 2%. You can see their one-year results. The important thing I want to explain here is that if you have an adequate vein, it doesn't matter if you have to go to a tibial or pedal target. The results are just as good in terms of primary and secondary patency. So it just points out again that for a good quality vein, the level of the distal anastomosis is not an important limitation. The biggest limitation is the quality of the vein and probably the quality of the surgeon. Again, it's pointed out that not all patients do well with bypass surgery. This is a different risk score compared to the one that Dr. Schneider showed yesterday that was derived specifically from the PREVENT-3 trial. But again, it's a similar finding. If you look at a couple of critical factors such as dialysis dependency, tissue loss, advanced age greater than 75, anemia, and advanced coronary disease, and you add these up, you can come up with a cohort that's very high risk. It's only about 10% of all the patients that were picked to get a bypass, but those patients did not do particularly well. In fact, their risk of death or amputation at 1 year was more than 50%. I don't think these patients really were serviced well necessarily, but I don't really know what better options they may have had. But the point is that clearly there's a group of patients, and this was confirmed in a larger cohort registry from VSG&E, or a similar size, I should say, that no matter how you slice it, surgeons are picking patients, some of whom, 5 to 10% of whom, are very high risk, and if we could avoid those, it might be better for those patients. Finally, the only randomized data we have so far is the basal trial. Most of you are familiar with it, so I won't belabor it. It's now a decade old. It was performed in the UK. About 450 patients with so-called advanced limb ischemia were randomized. One of the key difficulties with interpreting the trial is that these were so highly selected patients, and it's really not clear exactly what the criteria were, except that both an interventionalist and a surgeon had to agree that they were potentially reconstructible by either method. And that probably would look different today. It was only about 30% of all comers on an audit. So it's very difficult to interpret this, as Dr. Margolis would point out, in terms of your own practice. It's clear, however, that in the early phase, for the first 2 years, in this population, the two strategies look very similar. So for patients within 1 to 2 years, they look like they have similar efficacy, but you can see the curves begin to separate at 2 years. And again, it pointed out that about 70% of these patients actually live beyond 2 years. When they did subsequent follow-up, it was clear that after 2 years, bypass surgery was favored. And then when they looked actually at the treatments that were actually received, which is a little bit of a tricky thing because it's not really a randomized way to look at the data, but they did identify that patients who got their bypass with a prosthetic clearly didn't do very well. And importantly, those who got their bypass after a failed angioplasty did significantly more poorly than those who had gotten initial bypass. Now, this is important because this is what's happening in real-life practice. This is a review over the last 8 years from northern New England, looking at all lower extremity bypass grafts that had been performed and how many of them were done as a second procedure in the same leg because of either a failed bypass or a failed endovascular. And what you can see is happening in vascular surgery practice is over this time span, there's been about a 70% increase in the percentage of lower extremity bypasses that are not done as the first procedure in that leg. And so this is the new vascular epidemic that we're seeing in our clinic every day, previous treatment failure. We're treating previous treatment failure about as commonly as we're treating native disease. And the problem is it doesn't work as well. No matter whether we have a previous failed bypass or a previous failed intervention, and this was also propensity score adjusted for about 20 variables, we can see that patients who got a secondary procedure compared to a primary procedure don't do as well even within the first year and a half. And you can also see that these curves are separating more as time goes on. So the impact of treatment failure is real, and the success of the first treatment matters. So we're excited that actually with that background of data that we now have 2 randomized trials to look forward to, one in the US, the BEST CLI trial, which will start this spring. It's planning to enroll 2,100 patients, and also BASIL 2 will start within the next year in the UK, which will also be a new randomized controlled trial comparing open and endovascular therapy. So until then, my last 2 slides are basically how I currently approach this. I look at a selective approach for each individual patient, evaluating surgical risk, life expectancy, severity of ischemia, anatomy, and vein availability. And if I have a patient who looks like an average risk bypass patient with greater than 2 years expected life expectancy, major tissue loss or poor hemodynamics and severe anatomy, and if they have a vein, in general, those patients are going to get a bypass first. In my current practice, this is still about 50 to 60%. On the other hand, there's plenty of patients who are higher risk, who have more limited life expectancy, who may have minor lesions and more favorable vascular anatomy, and they may not have a good vein. So for those patients, I think an endo-first strategy is quite reasonable as long as you maintain close surveillance, as we pointed out. And finally, there are patients with poor functional status and limitations who really should be considered for palliation or primary amputation. So these are the final points. Treat the patient, not the lesion. Be flexible. Time is tissue, as Dr. Legerfo said yesterday. Don't fiddle and diddle, and the success of the first procedure does matter.